morning to all of you. Welcome to our 6th annual Research and Scholarship Day. For those of you who don't know me, my name is Archana Chatterjee. I am the chair of the Department of Pediatrics and delighted to see you all here this morning. We have a wonderful speaker this morning who will be introduced to you here in just a minute. Just want to remind everyone that we do have our poster session right after our grand rounds complete at 9 o'clock upstairs in room 106. So from 9 to 10 we'll have our poster session there and invite everyone to come and participate in the poster session. And we're going to go ahead and introduce our speaker here in a minute, Dr. Shalom D'Souza, who is an assistant professor of pediatrics and a pediatric neurologist, and a mentee of our speaker. Will be introducing him formally, but I'd just like to give Dr. Steve Roach, our Grand Round speaker, a very warm South Dakota welcome. We are very pleased to have you here today, Dr. Roach, and we have just a little recognition for you here, so please come up.
Thank you. Thank you very much.
And some things from South Dakota.
Okay. There you go. All right. Got it.
Thank you. We can get these down here.
Okay.
And Dr. D'Souza will introduce you.
All right.
Good morning, everyone. It is indeed my pleasure to introduce to you Dr. Roach. Like you know now, he is Section Chief, Professor, and Director of the Child Neurology Residency Program at Dell's Children Medical Center in Austin, Texas. So I first heard of Dr. Roach when I was a medical student in India. He was part of the legendary STOP trial aimed at prevention of stroke in patients with sickle cell anemia. I was told by my own attending back home that research like this makes sense because it changes everything for everyone, everywhere. As you know, he has had an illustrious career. Graduating from University of Tennessee Medical School and then training at Wake Forest. He has held numerous very successful academic appointments and has had numerous publications to his credit. When we met at Nationwide Children's Hospital, he had successfully changed a community hospital to a hospital that was regularly featured on the honor roll and was ranked 6th in the country for child neurology within a mere span of 12 years. In spite of his various achievements, the thing that always made me admire Dr. Roach was his humility and dedication to patient care. Should there ever be a stroke in the pediatric hospital, Dr. Roach would be with the pediatric resident examining the patient, even if it was 2 a.m. I also remember that even though he was chair to a department with 30 pediatric neurologists, he was on call Thanksgiving 2016. Numerous people in the hospital that day asked him why he agreed to take call when he had so many neurologists under him. And he said, "It is my turn, just like everyone else's." And I know this to be true because I was your resident that day. So without further delay, I would like to present to you Dr. Roach.
Wow. Some parts of that are
True, actually. Thank you. When I was asked to come here, what do you want to talk about? And I told them, well, I only know how to talk about 2 things. And one of them is tuberous sclerosis and the other one isn't. And so we picked tuberous sclerosis for this one, and the other one, I think I'm doing it. It has to do with stroke and the STOP trial and things of that sort. This is this material for me it's like one part history, one part clinical science, one part basic science, and one part personal journey. And for the residents in the room, I'd like to maybe start with a little bit of a personal beginning. My first interest in tuberous sclerosis dated from my internship. At the time, if you pulled a textbook and you looked at tuberous sclerosis, it's like 95% of them, you got the impression, 95% of them have epilepsy. Almost true. Almost all of them have severe cognitive impairment. Not so true. And maybe 5% of them have a giant cell sarcoma, which doesn't have to be fatal, but can be. And during my internship here, we had a little girl on the ward who had a giant cell astrocytoma that she subsequently died from. And she was not only normally intelligent, but was above average, played the piano, and so on. And my interest was sparked by, wow, that just ought not to be, right? I mean, here you have someone who's like, she's in the 5% group of getting the tumor, and she's also in the 5% group of getting normal intelligence. I found that fascinating and somewhat troubling, but quite literally, that was the spark of my interest. And so I think the lesson in there for you is if you have something unusual or you find something interesting, don't just sweep it under the rug. I was talking to one of your colleagues this morning about a little girl I saw in Texas who had a cholesterol of 600. And Joe Goldstein and Michael Brown had access to her DNA, and so they used that to figure out cholesterol. They got the Nobel Prize from it. But the real brilliance, I think, from that is that some pediatrician had to recognize, this is an important patient. And because Brown and Goldstein didn't see patients, let alone children. And so I think that every day, people like us are on the front lines of progress like that. And we may not be the person who can figure out cholesterol, but we can make our contribution. Anyway, disclosures, not much. If anybody knows of any enterprising drug reps who would like to give me a conflict, let me know. I do mention a few drugs here, but it's, I think, pretty much without exception in the context of research and as a part of the narrative. I'm not sure this is a conflict, but I disclose it anyway. I get an honorarium from Elsevier for being editor-in-chief of Pediatric Neurology. Joe and I were talking last night. A couple of three of your residents just published a very nice paper in Pediatric Neurology, so thank you. So here's sort of the roadmap for this morning. We'll talk briefly about the clinical features of tuberous sclerosis. That's a good topic for a general pediatric audience because it seems to have a little something for everybody. We'll talk about how we discover the two genes and what they do. And then we'll sort of veer off into the whole mTOR pathway that came from this. And then finally, there's increasing evidence that actually what we need to be doing for this disease is not being reactive, but being proactive and starting treatment before people get the complications. An overarching thing, not on the list, is I actually think that this is a good model for other genetic diseases because, back in the 80s when the genetic revolution was just starting, we were linking things to specific chromosomes, finding genes, et cetera, et cetera. There was this implied this implication that this is going to make diagnosis easier, that it's going to lead to new and unique treatments that are disease specific. And for many years, that promise was not realized. I mean, it helped with diagnosis in many of these. But this is an example of where drilling deeply into the genetics and the molecular biology of a disease has come now full circle into very specific treatments for that disease that actually work and make a difference in people's lives. And I think that if we can do this for something as difficult as tuberous sclerosis, then I think we can do it for other things. So I promised one part history. This at one time was known as Bourneville's disease. Bourneville, Desiree Bourneville, French guy, published his description in 1880. He kind of got a free ride, however, by Recklinghausen on Recklinghausen disease, and that actually published a patient, not as thoroughly, all the way back in 1862. Bourneville thought the skin lesions that we all recognize were coincidental, so he kind of missed the boat on there. But he did have a nice description of the brain pathology, and he was the one that termed the tuberous sclerosis. It's like a tuber. So anyway, that's where it all started. I'm not going to go through blow by blow everything since, but the point is we've known about this disease for over 150 years. And yet, probably most of the useful things that we know about it have been learned in the last 25 years. So, for those of you who maybe aren't familiar with this, just an overview, thumbnail. It's autosomal dominant with very frequent spontaneous mutations, depending on the series. Easily 2 out of 3, 3 out of 4 of the people who are diagnosed with this condition have a spontaneous mutation. The prevalence, if you look in the old books, you would see 1 in 100,000, something like that. And, I sort of suspected that was wrong even before the numbers got revised because, for something that's 1 in 1,000, why are we seeing it so often? 1 in 100,000. And so sure enough, if you do a population study, it's the prevalence comes up to be about 1 in 6,000 or 8,000. This affects multiple organ systems, striking phenotypic variability, right down to having very different phenotypes in identical twins or in people in the same family who have the same environment, they have the same gene mutation, and so on. And there's 2 genes, which we'll go over in more detail. And the 2 genes, the reason that the 2 genes on 2 different chromosomes gives you a very similar looking phenotype is the protein products of these 2 genes form a physical complex, heterodimer. And so the analogy that I use for the patients is, it's sort of like having a bicycle. It doesn't matter too much whether the front tire goes flat or the back tire, you still can't ride the bicycle. And then we'll go through the mTOR, the complex TSC1, TSC2 complex inhibits the mTOR complex, and and then finally this may have implications for some other diseases. So just as a brief introduction, many of you know this already, lots of characteristic, though not pathognomonic, skin lesions. The big picture on the left is a girl with facial angiofibromata. In the old text, you'll see this as referred to as adenoma sebaceum. It has nothing to do with sebaceous glands. In the bottom middle is a Chagrin patch. It's basically a connective tissue nevus. The facial lesions, you see those probably in about 75 or 80% of people, but you don't see them at a time where you often need to, which is in newborns. And they're pretty subtle for a while. Typically, these will start showing up as little red dots along about 4 years of age, and they get progressively more prominent over time. Probably maybe 35–40% of people will have a chagrin patch, which is that bottom connective tissue nevus. The big clue early is the hypomelanotic macules, or ash leaf spots. It's named ash leaf because it has the shape of an ash leaf. It's often oblong. and here you have, does that show up? Oh, well. And it has that oblong appearance. And in this picture here on the right, you'd actually see two. One that's sort of in the center of the picture, and over on the edge, there's another one on this woman's leg. The ungual fibroma up on near the finger is the least common of these. You see this probably 25% of the time, and it's a benign fibroma. It's not pathognomonic. We had a kid in the clinic the other day, in the residence clinic, who had one of these and had no evidence of tuberous sclerosis whatsoever. And I asked, when did this start? And the parents said, well, it started after he took a tumble off the stairs and trashed his toe. So it's trauma. So trauma is the other thing. Notice on this, though, there's a deep groove distal to that little fibroma. And part of the time, you'll see the groove, and the fibroma is buried up under the skin. So for purposes of diagnosis, if you see a deep groove, it implies the presence of a fibroma, and it will constitute one of the diagnostic criteria. And then retinal lesions. Here's a classic mulberry lesion. These calcify over time. They don't really cause you to go blind or anything, so their significance is mostly just in the aid to diagnosis. How frequent this is, it depends on who's looking, and the age and so on. I mean, babies are hard to look at. Older kids, not as much. Probably these occur about 75% of the time, although they're not usually quite so dramatic as this one. But the 75% is like with an ophthalmologist, dilated pupils, indirect ophthalmoscope. So ideal circumstances. If I look, knowing what I'm looking for, having seen, 500 or 600 of these patients, I would guess I can spot one of these maybe 40% of the time, and I would think that someone who's less practiced, would be probably doing well to see it 20% of the time. So it obviously depends on how obvious it is, how cooperative the patient is, and so on. Sorry for those of us who are eating breakfast. Renal lesions, renal angiomyolipomas, or AML as we call them, occur in about 75% of people who have this condition. This is obviously what we try to avoid, which is loss of the kidney, because guess what? They occur on both sides. So if your management strategy is to wait until it bleeds and then remove the kidney, that doesn't end so well for the patient, usually, because what happens when it does the same thing on the other side. Here you see the big one is sort of this fatty tumor, but then there's also a bunch of others that are identified by the ARIS. So when I started out with this, I was taught that, okay, if you don't have an angiomyolipoma in childhood by the time of diagnosis, that means you're probably not going to get one. Well, like so many things I was taught early, that turned out to be incorrect. So we did a study where we did annual ultrasound on about 60 people for over a period of years in childhood, same radiologist, same machine, and we identified each of the AMLs with a code, like an electronic tag. And so when we went back the next year, we could then compare year to year the same lesion. And one of the byproducts of that study is easily half of the people whose initial scan was completely normal by age 10 would have at least one. So you get them. Whether that means they were just too small to identify, who knows. Cardiac rhabdomyomas, this is a prenatal ultrasound here. Oh, it does work. And the large lesion with the fat era is the one that would be more likely to be clinically significant. You can see these without tuberous sclerosis, but when you see them as an isolated tumor they're usually solitary. So usually when you see more than one, it tracks to tuberous sclerosis. And this occurs in about 2/3 of children who have this, but most of the time it's asymptomatic. And if you do not have symptoms from one of these at the time you're born, you generally don't, because over time they shrink, not grow. So the way they show up is they'll show up as unexplained heart failure in a neonate because they have obstruction or whatever. Every now and then they'll show up as a wicked arrhythmia or something of that sort. If you can get these kids through the first few weeks without operating on them, they shrink. There have been a few papers about actually treating these with mTOR inhibitors, and they shrink more quickly. So if you have a critically ill baby, I would do that probably, because sometimes they're just too sick to tolerate going in and removing it. So, and then finally, not so much for this audience, but in adult women, it's probably 10 to 1 women over men. You have this pulmonary LAM, lymphangiomyomatosis, that goes with tuberous sclerosis. It too can occur isolated. Now, as a neurologist, of course, that's my thing. What about the neurology? Well, sure enough, the old adage about most of them having epilepsy is quite true. About, depending on what you read, 85, 95%. What's not true is that it's always intractable. You see plenty of these kids who respond just as nicely as any other kid with anti-epileptics or whatever. Intellectual disability, maybe 50%, certainly not the old number of almost all. And actually, a better number than 50% probably is the old rule of thirds that we sometimes use. A third of them are just plain normal. Another third are seriously impaired, like more than 50% loss of intellectual function. And another third are sort of functional, and maybe they're not as smart as their brothers, but they're not devastated either. So it's a broad range. Autism spectrum disorder is easily 25%, with probably about 10% of those having just full-blown autism, and the other 15 maybe being autism spectrum. And then giant cell astrocytoma, you see, depending on whether you're talking about symptomatic having to be removed or just MRI, 10 or 12%. So pretty common. Here's, if I were going to be making a question on this for the residents for the board exam, probably it would probably be the CT scan here. You get these subependymal calcifications as shown by the yellow arrow in the CT. You can also have calcifications out in the brain parenchyma, but the subependymal calcifications are virtually pathognomonic. I've seen something very similar to that in people who have some time ago gotten intrathecal meds and so on. You see something a little bit like that with cytomegalovirus, but that doesn't so much protrude into the ventricle. It's more it looks a little different, but it can be missed. What probably causes all the seizures and the cognitive change, on the other hand, is not the calcifications. It is these areas of cortical dysplasia on the surface. On the MRI, you can see them. And then there's the path slide that shows both of those. The epilepsy, it can be wickedly bad. So about a third of the patients who have it have intractable epilepsy. Another two out of three, it shows up in the first couple of years. And a large number of those, probably 2/3 of the ones of those 2-year group will show up with infantile spasms. So very, very specific. I've seen a number that as many as 10 or 15% of all infantile spasms cases will track back to tuberous sclerosis. So it's a serious cause of infantile spasms. It used to be said that, you can never stop their medicine, and that's sometimes true, if you're lucky enough to get them controlled. So Steve Sparagano and I, back in 2003, published this paper where we analyzed a bunch of people who had stopped medicine with tuberous sclerosis. Some of these were people who just ran out of medicine, didn't start it back. Some of them were people who actually were nice enough to ask us what we thought. And so we went through the usual deal. And it's not nearly as dire as all that. In fact, it's not all that different from what we tell regular people with epilepsy. That, okay, if you're neurologically normal, including cognition, if you've had no seizures in 3 years, and if your EEG is normal or nearly so, even if you do have tuberous sclerosis, you get away with it with about the same frequency as you would if somebody with epilepsy who doesn't have tuberous sclerosis. Increasingly, we've been learning that some of the tubers are worse than others, and if you can identify which of the tuber is causing the seizures and remove it, they do quite well with surgery. And then there's the other thing that tracks back to my very first paper on this in '87, that if you have the people who have more numerous and larger tubers on their MRI scan are, not surprisingly, more likely to have intractable epilepsy. They're more likely to have serious cognitive disorders. So there's a price to pay for these things. And then finally, the giant cell. Giant cells are named because many of the cells in this condition are just large. And we now kind of have an idea of why that is because of the molecular biology. But this is how they look on a scan. The picture there on the left is the worst giant cell astrocytoma I've ever encountered. This was a boy who was diagnosed as a 2-year-old, kind of followed by another neurologist for a while, and came in with bad headaches and trouble seeing and papilledema and so on, and had this huge tumor. So these are benign, but they do grow, and so you have to deal with them. And they, for reasons that are still unclear, almost all of these will arise in the anterior part of the lateral ventricle. So that's just where they come. So the picture in the middle is more of a typical thing, giant cell, so sagittal cut MRI, and that shows the location. It's a benign tumor, but with where it is, it'll block up the ventricular system, and if you don't deal with it in some fashion, it will slowly get worse and eventually kill the patient. So this is one of the areas where the new medicine really has just revolutionized everything. We used to try to take these out. If they were beyond taking out, we would shunt the patient because what actually gets you is the ventricular obstruction, and that would stabilize things for a while. Curiously enough, even though people, I think the oldest person I've ever seen with tuberous sclerosis has been 78 or so, and so, if you don't develop a fatal complication, you live a long time. But curiously enough, virtually all of the giant cell astrocytomas arise in the first decade and a half. And nobody's ever been able to explain that to me. So, now, turn our attention a little bit to the genetics of this. This paper from '87 was in Lancet prior, and this was one of the first non-X-linked genetic disorders linked to a specific chromosome. Not going to get into whether it was the first or not, but certainly this was sort of right at the cusp of all the wave of chromosome linkage, gene identification, and so on. And it was a clever paper because they used ABO blood groups, in large families, and because apparently they knew where those were. And so they used that and came to the conclusion that, okay, there's a gene for tuberous sclerosis on chromosome 9 because the tuberous sclerosis tracked with ABO. And so the problem then is when we started looking to try to confirm this, we very quickly identified other large families who clearly did not link to 9. They had negative LOD scores, or positive logical. And so that had to mean one of two things. Either they missed it, and it wasn't chromosome 9, or there was a second gene. And the data on 9 seemed to be pretty compellingly correct. So thus began the search for a second gene. And so it took 5 years, but with a collaborative group, we rounded up a bunch of other big families. I remember going to a couple of large family reunions in places in Texas I probably couldn't find again. You know, good food, nice people, you know, with a couple of outsiders over in the corner drawing blood. It's sort of an eerie day. But consequently, we did this. Ray Kant, who was at Duke, I mean, back in those, now if you were looking for a gene like this, you know, you call in your postdoc and say, look, I think there's a gene for this somewhere. You know, they'd have it worked out within a week. Then it was a little more akin to house-to-house fighting, you know, because you had like 2 or 3 markers per chromosome, and you had to do it, repeat. You know, you could work on something for several months, and at the end, the only conclusion you could make is, well, okay, it's not chromosome 18. And so Ray Kant did something pretty clever. Somebody had just linked just linked to chromosome 16 adult polycystic kidney disease. Well, about 1 or 2% of the time with tuberous sclerosis, they'll have the same phenotype. Lots of them have a few cysts, but some of them have the full polycystic kidney disease phenotype. In fact, we've seen people where that was the original diagnosis, and we only found the tuberous sclerosis part when they started having seizures later. So he said, well, maybe there's a connection there. Rather than just randomly starting to look at chromosomes, let's look at 16. And so it turned out to be a home run, because not only is it on chromosome 16, the 2 genes are side by side. So that explains a lot, because it explains why a good number of the people have cysts. It explains why you can have both phenotypes, because if you have a microdeletion that flips both of them, you nail both genes. And indeed, of the 2 genes, the TSC2 is the second one discovered, was what this was called. And almost everybody who has the polycystic kidney phenotype has TSC2. And in fact, even if you just have a fair number of cysts but don't have the full-blown phenotype, you still have 2 most of the time. So without going through all the rest, just to give you a kind of overview of unraveling the rest of it. So TSC1 linked on 87, TSC2 5 years later in Nature Genetics to 16. It didn't take very long then to identify the gene on chromosome 16. So TSC2, and then the protein product was named tuberin. So all that came very quickly. The TSC1 was a little more elusive, so it was a full 10 years after the linkage before that gene was identified. Then once that was identified, almost immediately the protein product was found. And then 1 year later, someone showed that these 2 proteins form a physical complex. So all of that within the span of just 10 or 11 years. So pretty good. The problem, remember I mentioned the phenotypic variability is just extreme on this. You'll see people in the same family. Dad's a bank vice president, has maybe skin lesions. The daughter has got kidney lesions and is going off to college next year. And the brother, 2 years younger, has intractable epilepsy, an IQ of 45, autism, and skin lesions. And none of this stuff on the genes really explains that, unfortunately. We've nibbled at it, but not that much. So there was an early attempt at that. So this is a paper we published in 2007. It's a genotype-phenotype correlation involving 325 patients. And So the red bar is TSC2, the blue is TSC1, and the NMI is no mutation identified. So these are people who had all undergone genetic testing, and sadly, even today, see, well, DNA is everything. Well, not really, because easily 10 or 12% of the people that you send off tests to the commercial labs will come back negative, even though they meet criteria. And if you send that patient to a research lab, where they have unlimited time and you can tease it out, most of them have mosaic. So what you're basically missing, they still have it, but most of them are mosaic. So the DNA tests are not the answer to everything. So, but what's clear from this is TSC2, regardless of which aspect you're looking at, is a worse disease than TSC1. So to bring back my bicycle analogy, yeah, you can't ride the bicycle if the front tire or the back tire is flat, but clearly the front tire is worse because you can't steer. So even the bicycle analogy, one tire is a little worse. And we now know why this is, because this complex, the function of the TSC1 complex, it's basically a chaperone protein that keeps TSC2 protein from clumping together. So TSC2 is the real business arm of this, and TSC1 is just a sort of filler to keep it from clumping. So it'll mess you up either way, but clearly TSC2 is a worse mutation. It's also a more fragile gene. So if you look at this cohort of 325 people, 60% of them have TSC2 mutation. And then the other thing is, if you look at the people who have no mutation identified, it was typically benign. A lot of them were benign. They met diagnostic criteria. Some of these were known to have a mosaic because they'd been studied in a research lab. But clearly TSC2 is the worst, TSC1 is second, and if you meet criteria and have no mutation identified, that's better. And that stands to reason, because if you think about it, if they're mosaic, well, depending on where the mutation occurred in gestation, they may have only 10% of their cells affected, or 50% or whatever, but certainly it ought to be a more benign disease, because you have a cohort of cells that are just normal. And then mixed and mingled, you have others that are not. So what can we say about all this variation? Well, we can say some of it. Some of it is age-related, some of it's sex-related. So I mentioned the pulmonary disease. That's known to be exacerbated by estrogen, and I have seen pulmonary disease in males, but not very much. And you almost never see that in children, so that's also an example of age-related. You don't usually see new giant cell astrocytomas in people over 15 or 16. So there's all sorts of age-related stuff, some of which we can understand. The gene and mutation type explains a little bit of it. TSC2 is worse. A mutation type that just basically inactivates the protein is going to be worse than a point mutation that just kind of modifies it a little bit. Most of the tumors you can explain by second hit. So this is a tumor suppressor gene, and so if you get another mutation, not necessarily even in the tuberous sclerosis gene, but if you do that, that's what presumably triggers the tumor formation. And sure enough, if you analyze tumor specimens, you will find the same mutation that's in their bloodstream, and most of the time you'll find another mutation. So that explains the tumors. And then somatic mosaicism, germline mosaicism, the somatic mosaic would explain, say, the father who was the bank vice president, because he's probably mosaic, whereas both of his children offspring would have the whole disease or nothing. And then germline, we kept seeing occasional people where the parents had no evidence of this, and they'd have a child and then they'd have another child. And so if you analyze those children, we published a paper about 6 of those families, and the only real explanation is a germline mosaic. So in other words, they have a mutation in the gonads. And, you wouldn't find this on a blood test. Curiously enough, out of those 6, every one of them came from the mother for some reason. I'm not sure. That's a small enough number that I'm not sure that's significant. And then, of course, there's other things, other genes that can affect the same pathway. The problem, though, is even identical twins will end up being very different. I know a set of twins in Texas. One of them went to college. One of them has a good job. They're both in their 30s now. The other one is institutionalized. And they're identical twins. So there's still some things about this we don't know. So what do these genes do? We've talked about the first 2 already. The complex inhibits the mTOR cascade, a G protein, and dysfunction of either potentiates mTOR activity, and so that in turn increases biosynthesis. You can read this. I'm not going to read the whole slide. The one thing, though, that was apparent very early is you see the homologs of these genes all across species. In fact, one influential early paper was done in Drosophila fruit flies by a couple of my colleagues at UT Southwestern. And so that should have told us very early on that this is not just some trivial little branch of the evolutionary pathway, but it's really central. And until we got into this, with tuberous sclerosis research, this is largely unknown. So that's a, believe it or not, somewhat simplified thing. I'm not going to go over this in detail. If anybody wants it, I'll send it to you. So what we're finding is this dysfunction of this pathway does a lot of bad stuff. The first thing they found out with the Drosophila is that it impairs insulin signaling. It promotes tumor formation, cell growth. You get large cells, you get tumors. It impairs cell differentiation. You get disrupted neuronal migration, which probably explains the cortical dysplasias. Abnormal myelination explains part of the other brain lesion. And it alters angiogenesis. So in the kidneys, one of the bad problems there is not just the tumor, but it's the blood vessels that go to it. They'll present often with just hemorrhage, retroperitoneal hemorrhage. So what is this mTOR? Well, originally it was mammalian target of rapamycin, and that cryptic name, I think, tells you what you need to know about our understanding of the whole pathway, because they knew rapamycin did something. They knew that it must have a target. They kind of knew generally what it was, but that's about it. And then somewhat inconveniently, it started showing up in fruit flies and things like that. And somebody said, well, wait a minute, this is not just mammalian, after all. And then so somebody came back and said, well, maybe we could change the mammalian to something else. But of course, now mTOR is all in the literature. And so they came up with, well, maybe we could call it the mechanistic evidence. So we changed the name, and I always thought that was cute. And so rapamycin, sirolimus, is shown on the let's see, on the left. And the new drug that's actually FDA approved is the other one, everolimus. And I put this picture in because I don't know, those of you in the audience who have just a little bit of a skeptical or even cynical streak might start to wonder that this old drug, rapamycin, that's patents have been off for years, gee, isn't it wonderful how you can create a new patent by just adding a hydroxyl group? So now the people who manufacture this said, wow, but this drug only hits complex 1 of the mTOR pattern. I've got all this spiel. I'm not sure I believe it. But anyway, it is good to have more than one drug, and maybe it does something different. And there's some others in the pathway. So as soon as this connection to mTOR appeared, people started thinking, well, how could we harness this? So Dave France in Cincinnati tried, he just took some people with giant cell astrocytomas and put them on rapamycin. And, this is not controlled or anything. In fact, these 4 pictures come from one particular patient, I think there was 6 or 8 patients in this Annals of Neurology paper, but I think it illustrates things very well. So panel A is the MRI before before treatment. So you see a characteristic giant cell in a characteristic place, and of course it backs up the ventricular system, so you have hydrocephalus. B is after 2.5 months of therapy, same patient, almost exactly the same cut through the MRI, so it's much smaller. They stopped it. And panel C is after treatment was halted for 4 months. It's right back. There's virtually no difference between panel A and panel C. And then therapy again for 8 months, and the 4th MRI shows that it's largely gone again. So this is the good news and the bad news. It works pretty well, but it doesn't get rid of anything forever. You know, it's sort of like putting air in or out of a balloon almost, but it's a good treatment. So then we're off to the races. So John Bisler, who's now at St. Jude, I think, was in Cincinnati, and he tried this for a bunch of people of all ages with renal angiomyolopomas. And this graph at the bottom, each of those lines represents a single patient. So, and the pictures at the top are before and after for a given patient, so same patient. And so what you can see, he had his treat, non-treat, follow-up, and so most of the patients had the tumor shrink. And then for the first year, and then for the second year, you stopped the treatment, and most of them, but not all. Some of them, kind of shrank it down, and the tumor kind of stayed quiescent. But most of them, it starts getting big again. But this treatment's pretty well tolerated. You get a few mouth ulcers, and you have to watch the blood counts a little bit, but it's not like major chemo as we know it. John also looked at LAM, and so here you have forced vital capacity, concentrating on that top line. So sure enough, forced vital capacity increased in the people who had pulmonary disease over the first 12 months while they were on it. You stopped it, and it starts drifting back down again. This also works in people with isolated LAM, so it's probably related. And then here's another trial. You can actually mix this stuff up in a cream, and they did this trial back like 5 years ago. Why it took them until last year to get it published, I don't know. But and so here's the same patient with facial angiofibromas, and after a course of cream. It's a difficult drug to study in the usual ways, because if you can imagine, okay, what if you had a dummy cream, right? Like a placebo. Well, if the kid comes in a month later and he still looks the same, the family's going to know that he's on placebo, the doctor's going to know that he's on placebo. And moreover, though, when they started doing clinical trials with either of these drugs, this is a problem, because if you take it orally, you also shrink the skin lesion. So there is no traditional blinding of this. I mean, because anybody who's going to be in a position to do these trials knows that they can spot who's on it a week or less, and the families can too. So sure, you use placebo, and you're kidding yourself if you think that it's truly a blinded placebo, because this gives it away. But this is a nice technique, because you don't absorb very much of this, and so it's very little toxicity. The new mTOR inhibitor that I showed you is everolimus, supposedly selective inhibition of the complex 1 of the mTOR complex. It's now FDA approved for giant cell tumors, renal angiomyolopomas, and for epilepsy, which we'll come back to. When we're doing the tumor trials, some of the parents kept coming in, and you'd look at their seizure logs, and sure enough, somebody who used to have 20 seizures a month, they'd come in, their logs are now 5. They weren't seizure-free, but it's a definite dip. And some of the parents would say, well, my autistic child is much more interactive, and they're learning better and things. So eventually they did separate trials for epilepsy and for cognitive disorder. The bottom line is epilepsy, worked well enough that it got them an FDA indication for intractable epilepsy for tuberous sclerosis. The cognition trial didn't show much. So. And so here's just quickly, this is sort of like the rapamycin picture. This is a baseline 3 months later, just a different drug. Again, it shrank. Darcy Kruger published this in 2010 in New England Journal of Medicine. And I put this in, it's a kind of heavy data, but I think it shows one or two things very well. 28 patients in this series, it was not randomized, so all the patients got the drug. And the bar here is the percentage decrease in the giant cell. And so I think the takeaway is every single patient decreased at least some, every one of them. 28, let's see, 17 of the 28 actually had it reduced more than 50%. So it's a good drug for this, and it's virtually eliminated the need to do surgery. Then we did a randomized trial, which basically showed the same thing. It was 117 patients. Two got drug, one got placebo. Primary endpoint was reduction by 50%. Placebo, 39 patients, none of them got any better, not surprisingly. 27 of the 78 hit the 50% mark, but of course most of the rest of them hit something a little short of that. Another randomized trial also confirmed the utility for AML, so we're not going to go over that. And then I think I've already talked about this, so that came out in 2016, this article by French. David Kwiatkowski and I had a Lancet editorial about it. You know, it's good, but it's not revolutionary, and we did a little quick calculation, which we kind of gigged them a little bit about in the editorial, that, okay, we had the data, and for every seizure, you know, if you look at before and after, for every seizure that you eliminated by adding this drug, cost something like $9,000, because it's an expensive drug. So you don't usually start with this drug. What about preemptive therapy? Well, there's some pretty good evidence. You can see the EEG change. So if you take someone that you know has tuberous sclerosis because of a cardiac rhabdo or because of skin lesions or family history or whatever, often, you know, if they're not having seizures, they'll have a normal EEG. And if you do a monthly EEG on these kids, you can actually see it start to build. And, you know, it'll be abnormal, and the next one is more abnormal, and then they start having seizures. So you can actually see the storm coming. And there's a recently completed trial in Poland where they randomly assigned these kids to the gabapentin, the ones that had an abnormal EEG. And what they found was pretty stunning. Gabapentin has some mTOR inhibition to it. It's a seizure drug that works other ways too. But what they found is delayed seizure onset, and since you're talking about a critical time for development, even if you have seizures, delaying it for a year is quite significant. More patients were seizure-free later, although they were still on other drugs, and improved cognition later. And this is, as far as we could tell, the only variable there was starting it before the seizure started. The other question is, would mTOR therapy prior to this prevent some of the manifestations? My prediction is within the next decade, the treatment here will be when you make a diagnosis, you will start them on an mTOR inhibitor. And before anybody asks, no, you can't start it before birth because, at least in animals, when you do that, you induce an abortion. So that won't work. But early childhood, yeah. And so what's that based on? Well, okay, you go to our old friend, the knockout mouse, and if nothing else, I'm HIPAA compliant. So here's a TSC1 conditional knockout. And so basically, if you do nothing, they live about 25 days, and then they start to die off. And by a couple of months, they're all dead. The controls, you know, they're living in their cage, happy, healthy, three squares a day. If you take that same mouse and you give them rapamycin, well, the controls looks about the same. They're all dead within 2 months. The ones who get the rapamycin, here's one that didn't make it, you know, for some reason, but most of them are still alive. And then if you stop it after 30 days, basically all you do is shift the curve. So about the same period of time after you stop it, they start dying off. Here's the new drug, the chemical name for it. If this is everolimus, it's the same thing. So if you treat them, you rescue them. If you stop it after 30 days, then they start dying off. So, so you would guess anyway that you could rescue people and keep them from doing things. Well, here's from the same study. These are myelin stains, so control. This is what myelin is supposed to look like. We're not going to get into where it is, but just basically it's supposed to look nice and crimson looking. The mutation animals have very little of this crimson, so they have very little myelination in their brain. And if you look at the ones where they got the mutation plus the rapamycin rescue, then it starts to look much more akin to normal again. So that's pretty good animal evidence. The large cells, the mutant mice, they have these larger than normal brain cells. The rapamycin keeps them from getting large, and if you do a cell analysis, you go through that. Basically, the rapamycin keeps the cells from getting large. So it's a really effective. What are the next challenges? Because this is just one chapter or maybe two chapters in a story that has to go on. The big issue, I think, next clinically is when should treatment begin? I mean, the EEG data clearly, I think, indicates that the earlier you start treatment, the better, maybe even before the seizures start. Right now, that would be with vigabatrin, but my prediction is it's going to be with a stronger mTOR inhibitor. The earlier use of mTOR inhibitors, possibly lifelong, to keep them from getting giant cell tumors, kidney tumors, I suspect is where we're going with this. There's several other mTOR inhibitors in the pipeline. Will mTOR inhibitors benefit other issues? Yep. They're already using it off-label, of course, for various cancers and so on. In fact, I've always been a little bit skeptical that the drug company spent millions of dollars to capture the market of something that happens once every 6 or 8,000 people. So I think that they used tuberous sclerosis as a convenient model where the molecular biology was worked out well and they knew they could get it on the market, knowing full well that it would then broaden into the general cancer market, and it's doing so. Apparently it's quite effective for some types. Care of adults with tuberous sclerosis is a huge issue. The people who really truly know this disease, I think, are the child neurologists, the pediatric geneticists in particular. Other people sort of know their area, but then it's like you get to age 18 or 21, and it's, after that, it's kind of a wasteland for the most part. So that's a problem we got to fix, because these individuals don't just die when they get 21. So they, almost all of them, if they don't get a fatal complication, they're into adulthood, and I usually keep seeing them, but it's not ideal. So take-home points. This affects lots of organs. It affects some of the organs we didn't even talk about, like bone and liver and stuff. Similar phenotypes because the gene products form a complex. Variable phenotype, TSC2 worse than 1. mTOR inhibitors benefit some of the complications at least, and pre-symptomatic therapy may prevent some of those. And again, I would say that as a model for how to approach a genetic disease, I think we can take home a lot from that. If we can drill deeply enough into an understanding of the molecular biology, then we might see targeted disease-specific therapy come out for things like Down syndrome and Fragile X and other things. I think if we can do it for this, we can do it for others. So with that, I will quit. Thank you very much.